Now, Dr. Ramraj was a very gifted surgeon with literally magic in his fingers. He's going to tell us about how he would advise to proceed in case of an infected patient. Dr. Ramraj, please.
Respected chairpersons and dear friends, good morning to everybody. Warm regards from Cosmopolitan Hospital where I am attached to and my buddy, Dr. Vishnu ML. There is a direction that I need to have the introductory slides, but I strongly believe that I am non-existent without mentioning my teachers. I have to mention the name of at least Professor Shankaran, Dr. Jainendra Kumar, Dr. P.R. Venugopal and Madhumohan sir here. I am fortunate to have Madhumohan sir and Mohan sir and the other chairperson sir here to chair this session. I am really fortunate. I can't mention all names here. Now, we know Bassini, father of modern herniology, who said, those who cannot remember the past are condemned to repeat it. Infected mesh is equal to infection plus mesh. I would start with an equation of this nature. It's a most unfortunate event with regard to the patient and most disgusting for a doctor to treat. Now coming to the definition of infected mesh. It's a deep incisional surgical site infection where the infection normally happens within the first 1 year of operation when a prosthetic was used and when it is related to the procedure that was done and when it is related to the incision and the deep fascia and the muscle layer attached to it. The bacteriology is most common is Staphylococcus aureus. It gets attached to the mesh, leads to proliferation subsequently, releases the exopolysaccharides forming the biofilm and thus become immune to any sort of intervention, that is antibiotics or whatever modality that you attend on. Little bit of recapitulation of what mesh is. Basic categorization to absorbable and non-absorbable. We have the other types now. I'm not mentioning those for paucity of time. What is an ideal mesh? It is a lightweight, monofilament, hydrophobic. We have an entity called water contact angle, which is more than 90 when you call it as hydrophobic. Thereby, the bacteria gets less adhered to the mesh and the issue becomes rather a difficult task for the bacteria to pave way. Pore size should be more than 1 millimeter and absorbable mesh should be used in an area of contamination. We have certain risk factors associated with mesh infection which have been elucidated in the different studies that have been undertaken. Those are enumerated here. We have the patient factors and the surgeon factors. Patient factors, as we know, basically the advanced age, high BMI, high ASA score, tobacco smoking, poorly controlled diabetes, immunosuppression, pre-existing skin disorders, and emergency operation, especially those carried out where you have inadvertent enterotomies. And the surgeon factors basically are long operating time, especially by a low volume surgeon, inadequate hemostasis, a resident operating has been mentioned in few studies. It doesn't mean that an experienced person is immune to this. Site of placement of the mesh also has been found to be important. Coming to the diagnosis, we have symptoms and signs of fever, malaise and all that. Leukocytosis, elevated ESR are identified. Basic tools that you utilize for the diagnosis are basically ultrasound, CT and MRI. A technetium 99 anti-granulocyte antibody scintigraphy at times becomes helpful to define exactly whether there is an existent infection or is it an allergy. This is an ultrasound showing a floating mesh. Other one is a CT with a prepectoral collection. Treatment has always been controversial because of limited data that's available. However, various organizations have come forward with different modalities of treatment where the fluid aspiration followed by microbiological workup, target antibiotics, especially for a longer duration, has been proposed. Debridement and VAC-assisted treatment protocols have been helpful, but the basic difficulty that is faced within this situation is that the exact time when the pathology presents is not something that you can postulate. It has been seen from 4 months to almost 4 years. However, the results with this sort of modality of treatment, that is aspiration followed by antibiotic, has been poor, and most of the time you'll be forced to go ahead with the next modality of treatment. Here we see that the needle is going inside and doing the aspiration. A small mention about atypical mycobacteria which has to be mentioned in a discussion of this nature. Fortuitum is the commonest. You require long term, that is almost 4 to 6 months therapy with clarithromycin, ciprofloxacin, which is the one that is involved. And mesh removal is the most unfortunate and the inevitable. It is natural that the patient continues to believe that's a problem that the surgeon has caused, and the surgeon feel it hesitant to attend on the issue. But however, we have to proceed with it when it becomes inevitable. You can categorize it into either a partial excision or a complete excision. Partial mesh excision, the advantages are shorter stay, less morbidity, a risk of persistent infection because of residual foreign body inside. Foreign body continues to have create problems there, but revision procedure almost always become a mandatory requirement. Whereas when it comes to a complete excision, we find that the morbidity is high, it's a difficult procedure, it may lead to enterotomies, resections, and the most important issue that addressed here was in most of the studies, there is ischemia to the abdominal wall and the panicle, resulting in a poor outcome and recurrence of hernia as an issue. So whenever safe, this message has to be carried out. The entire mesh, all sutures, all foreign materials to be removed without any compromise. So here you can see that the methylene blue injection is into the sinus tract. That excision process is underway. It is pedicled onto the intestine that is affected, resulting in excision of the entire intestine, the affected segment of the intestine, restoration of the abdominal wall. So the hernia repair after mesh removal has been a concern, and people have attempted different types of repairs. Single stage procedure is where you go ahead with a primary repair with a suture, where there has been documented almost 80% recurrence of hernia, and the patient has to be counseled for a subsequent procedure. But most of the patients, there have been poor turn-up and they continue to live with a poor quality of life. The best option therefore would be a best primary repair itself, whenever possible, to achieve a facial closure and avoid a bridge repair. The use of permanent mesh in the primary explantation is best avoided. This is a pictorial representation of explantation being carried out, followed by a replacement with a biological mesh, and those to avoid an infected mesh. In fact, this is the most important thing. When you are going ahead with the first primary surgery for a hernia, if you can follow these steps, study your patient thoroughly, perfect pre-optimization without any compromise, adherence to the surgical principles, proper techniques carried out, mesh, what mesh to be used, when it is to be used, how it is to be placed. Is there a possibility that you can avoid a mesh when it is really not necessary? And followed by perioperative antibiotics and aftercare would necessarily give you good results. The entirety of what I have been trying to express in this few previous slides is demonstrable with the statements from these stalwarts of years. Cooper said, "No disease of the human body belonging to the province of the surgeon requires in its treatment a greater combination of accurate anatomical knowledge with surgical skills than hernia in all its varieties." Whereas another 100 years, the statement is, if we could artificially produce tissues to the density and toughness of the fascia and tendon, the secret of radical cure of hernia would be discovered. This is by Theodore Billroth. And another 100 years, processes, whatever their value, cannot replace a full knowledge of the underlying anatomy and pathology of hernia or substitute for the exercise of time-honored principles of surgical technique. I think the message is clear here. 200 years have taught us so many things. Now when do's goes 10%, don'ts in fact fail to have its place. Therefore I conclude with a question, is it a preventable calamity? Thank you very much.
Thank you, Dr. Ramraj, for your excellent presentation. Any questions from the floor?
To suspect an atypical mycobacteria, what is the regime you follow, sir?
Atypical mycobacteria, you have to go for culture, go for targeted investigation protocols, start on the specific treatment. That's clarithromycin and ciprofloxacin is the one that is in vogue right now.
So how long do you give it usually?
4 to 6 months.
4 to 6 months. Would patient tolerate it, this regime?
You have to. But once you have documented that the infection doesn't settle with that, most of the time you don't wait for the fibrotic process to come in. The patient has to be forewarned that may not be the only cause. So I just have experience of 4 cases only where I have done explantation. I have found that it's a mixed flora most of the time. Say typical mycobacterium was treated, however the response was poor, finally ended up in explantation because of subsequent other flora coming in.
Thank you, Dr. Ramraj.
Thank you very much.